I'm Dr. Jackie Pallis, and I'm going to cover the treatment of NMOSD and MOG antibody disease. And I'm going to talk not only about the new and more expensive treatments, but also about the old, cheaper treatments. So what conditions am I going to cover? So I think this is the easiest way to explain it. If you think about the NMOSD 2015 criteria, the majority of patients will have aquaporin 4 antibody disease. And if they have just one site affected, then they fall within the criteria. If they have diencephalic or cerebral involvement, then they need typical MRI changes. Otherwise, they don't. However, if patients have no aquaporin 4 antibodies, then the criteria are different. They're more rigorous. To fulfill the criteria, they have to have at least 2 anatomical sites affected, all with typical MRI changes, and at least one of these affecting one of the typical areas, such as optic neuritis, spinal cord disease, or area postrema involvement. And they can have recurrent or monophasic disease. Those who only have one site affected don't fall within these criteria, but for all intents and purposes, they can behave very similarly, and I will be covering these as well in my talk. Now, about half of the patients who have aquaporin 4 antibody negative NMOSD will have MOG antibodies, and they also be found in the one site types of patients, but also they will be in ADEM patients and a rarer cortical disease with seizure type. And those that are left over are antibody negative. And it's just highlighted these. There is a difference clearly, therefore, between aquaporin 4 antibody negative patients and antibody negative patients. So there are 3 different scenarios to consider: how we treat the acute attacks, how we prevent future relapses in these 3 scenarios, and then also trying to prevent early relapses or rebound from a MOG antibody attack. I think this is a much easier way of thinking about treatment. So does the patient have monophasic disease or are they relapsing? You can see here if they're aquaporin 4 antibody positive, then we regard them as having relapsing disease. But antibody negative and MOG antibody patients can be monophasic or relapsing. For the purposes of treating the acute attack, where they often present very similarly with severe optic neuritises, brain attacks, or cord attacks, really treat them in the same way. So I think urgent treatment with IV methylprednisolone is important. We treat between 3 and 7 days of 1 gram, depending how severe it is. And if there's a poor response or they have very severe disability, then prompt interaction with a second-line treatment such as plasma exchange or IVIG if you don't have access to it, or if they've only had a short course of IV methylprednisolone, you can try a little more, especially while awaiting to set up plasma exchange. But where is the evidence for this? So I think this was a very good retrospective study that the NMOSD group reported. They had 185 patients, the majority had aquaporin 4 antibodies, and they looked at nearly 900 attacks. And they classified them according to the treatment as to whether they had a complete remission, partial remission, or no remission. And they compared high-dose steroids to plasma exchange, as those were the biggest groups. And overall, there was no benefit of plasma exchange, first line, except in transverse myelitis. And you can see here, on the left is the high-dose steroids group, on the right is the plasma exchange group. The red is the complete remitters, and there is a greater percentage of patients who completely remitted despite the fact they had worse disability to start with. In the plasma exchange group, there was no difference in the non-remitters, that's the black. They then went ahead and they looked at whether there was a benefit of second-line treatment, third-line treatment, fourth-line treatment, and these were a mix of treatments they were looking at. So here you can see in order, first, second, third, and fourth-line treatment. And up here in the light grey, there wasn't really any difference in the complete remitters, but from the first line to the second line, they reduced the no remission rate by approximately a half. And then third and fourth line reduced it by about 1% further. It was significant, but it was a small effect. So I think from here we can say that second line treatment are not really going to increase the complete remission rates, but they reduce the non-responders, but further treatment after second line gives little benefit. It is also important to note that they included all treatments up to 3 months from relapse onset. This allowed them to study the effects of time to treatment. And in their regression modeling, they were able to show that for every day there was a significant reduced risk of complete remission. And if you extrapolate this to a 7-day delay, this works out at a 30% reduction risk of getting complete remission, and at 1 month, 77%. So early treatment is very important. They also noted that older age, lack of complete remission in previous attacks, and a transverse myelitis attack was more likely to have a poor outcome, and therefore these are the patients you might consider treating quicker and more aggressively. So now we come on to relapse prevention, and as I've already said, aquaporin 4 antibody disease is a relapsing condition, even if you see them at the first attack, and therefore we would always start relapse prevention therapy from the word go, whereas for MOG antibody disease and antibody negative disease, we would start when they're relapsing. And the data for these latter conditions is less clear than in aquaporin 4 disease, where it's been more studied. So this is a reminder that in all the antibody conditions that we're talking about, relapse is responsible for the disability. And this is from a study which actually looked at the permanent disability left from the onset attack in aquaporin 4 antibody positive patients. And 24% of patients were left with EDSS score of 6 or greater, 14% were left wheelchair bound, and nearly 20% were left with permanent visual loss that was severe bilaterally. So it's really crucial to prevent relapses. So this is an algorithm adapted from Practical Neurology paper. And on the left, you can see the standard treatments that many people use: prednisolone and or azathioprine or mycophenolate, methotrexate or rituximab. And I've highlighted prednisolone in yellow because I think these patients are usually very responsive to prednisolone. It's just whether they can tolerate it. So we often keep our patients on low dose prednisolone, even when using a steroid sparer. And then if they don't respond to these treatments and you have to put them on an adequate dose for a sufficient length of time, then you can try one of the other therapies. And then I've listed here cyclosporine and tacrolimus and some of the other immunosuppressive therapies that have been used in other antibody conditions. And I've not mentioned here the newer treatments because I'll come on to them later. Now, it does seem clear that rituximab is more effective than mycophenolate, which is more effective than azathioprine. This is a good report. It's a retrospective analysis of first-line therapy from the Korean group on the left, and it's time to relapse, and the majority of these patients had aquaporin 4 antibodies. And you can see that patients on azathioprine at the bottom were quicker to relapse than patients on mycophenolate that were quicker to relapse than those on rituximab. And on the right, this is an analysis from the Korean group, but joining many different groups' data together. And they looked at the predictors of worse outcome regarding EDSS 6 or more or visual loss that was severe. And what you can see outlined is that mycophenolate and rituximab had about a half risk of developing an EDSS score that was greater than or equal to 6, and that rituximab had a 60% reduced risk, so a 0.6 odds ratio of poor visual outcome. So this would be compatible with the idea that rituximab is more effective and maybe mycophenolate more effective than azathioprine. There has been one open label randomized study comparing rituximab to azathioprine with prednisolone. This is from the Iranian group. And you can see here there were just over 40 patients in each group. And the data is shown here, the results. So in orange, it's the rituximab results, and in blue, the aza with prednisolone group. And there were more patients in rituximab that were relapse-free. This was significant. If you look in the middle columns, before rituximab, patients had a higher relapse rate, but after they had a lower relapse rate than the equal times in the azathioprine group. And then to the right, the EDSS improvement was significantly better in the rituximab group than the azathioprine group, even though they were more disabled to start with. It's also worthwhile noting that rituximab can have a delayed effect. This is a nice figure demonstrating this. You can see that they're put on rituximab at time 0, all the relapses before, and then there are more relapses early on, and over time they tend to die out. Why might this be? Well, within this group from the Korean centers, they demonstrated there were patients who did this. So what you can see is that the B cell marker, which in this case was CD27, many people monitor CD19, the B cells were suppressed, but the aquaporin 4 antibodies were high for quite a long period before they came down. And in some patients, despite the B cells being suppressed for the majority of time, the aquaporin 4 antibodies continue to be high. So this may be the explanation. So this is to remind you the B cell lineage where they maturate and then become plasmablasts and then plasma cells. And it's only the latter two, particularly the plasma cells, that actually produce the antibodies. But the anti-CD20 treatments will only bind to the early part of this pathway, not to the cells that actually produce the antibodies. And so it may take a while for the effects of depleting the B cells, for the long-lived plasma cells to actually die out and not be replaced. We measure the CD19. Obviously, you might be able to measure some plasmablasts initially for a while. But what's really important is a drug that might actually get rid of anti-CD19 expressing cells might actually work further downstream and might affect more quickly the cells producing the antibodies. This is relevant for later. Also, rituximab is not magic. We still get failures, and this is just to remind you, on the left was the figure that I showed earlier. 25% of the Ritux patients did relapse even when it was used first line, according to this. And on the right is a French study where they looked at rituximab being used second or third line. And what they noted were nearly half the patients relapsed within 2.5 years. Going back to the combined data that the Korean group analyzed from a number of different centers, they also did a time to treatment analysis to see if the sooner you gave people immunosuppression, the better the outcomes. And they did find that for every year delay, you were more likely to become disabled on the EDSS score and more likely to become visually impaired. I'd just like to talk about some of the less common drugs that are cheap, that are sometimes used in these conditions. So there are two case series I show here of the use of methotrexate in aquaporin 4 antibody disease. In the first study, they were used more frequently as second line than in the second study on the right. The relapse-free rates were higher in the first study, nearly 60%, rather they were about 20% in the other study. There was an 87% reduction in relapse rate in the larger study and 64% in the second study. And about a third of patients stopped in both studies, presumably because they relapsed. But it does seem that methotrexate definitely has an effect on reducing relapses. Here's a case series of the use of cyclosporine, and this is just an observational study of 9 patients from Japan that were on cyclosporine and 9 patients on azathioprine. Both showed a reduction in prednisolone dose. Both showed a reduction in relapse rate, cyclosporine at least as good as azathioprine. These were all aquaporin 4 antibody positive. And a few studies of tacrolimus. The first 2 on the left, both were looking at reporting 25 patients. The first one reported just 8% relapse, but it was in a year. The second one, 20% relapsed within the year. There was an 86% reduction in relapse rate. And the majority of these were aquaporin 4 antibody positive. On the right, from Japan, there was a report of 42 patients that were all aquaporin 4 positive, shown here. And there was a 92% reduction in relapse rate, and 31% of them were relapse-free. And this was from a median follow-up of about 5 years. So maybe tacrolimus is more effective even than cyclosporine. It is really crucial to be aware that many of the MS disease-modifying therapies actually make aquaporin 4 antibody disease worse. This is a nice figure demonstrating the increase in relapses in patients that went on interferon beta. There are many, many other studies that show exactly the same. In the MS study of fingolimod in Japan, 4 patients were later identified to have aquaporin 4 antibodies. And when they went back and looked at what happened when they were put on fingolimod, they all had relapses, some of them many relapses, and some of them devastating with permanent disability. This is from a French group who showed that when they took their patients that had been put on glatiramer acetate off glatiramer acetate, the relapse rate went down. There have been many reports of natalizumab and one of alemtuzumab causing severe disability and even death. And more recently, dimethyl fumarate has been reported to show catastrophic relapses. In addition to the MS-DMTs, there's a question around cyclophosphamide. So on the left, there was a report of 4 patients, half of them relapsed, and the third had sepsis. Their follow-up for these patients was nearly 4 years. But on the right, a study of 7 patients from Brazil was quite worrying. So they used cyclophosphamide, first line, pulse cyclophosphamide. One of the patients was lost to follow-up, and 5 out of their 6 patients relapsed, and one of them died because of a severe relapse. So only 1 patient seemed to respond, and the other remaining 5 were switched to azathioprine and prednisolone and did much better on it. Mitoxantrone, does this work? Well, this is a study from the NMOSD group again, where there's an observational study where they looked at 34 patients in their study, with a majority had aquaporin 4 antibody disease, and they compared their outcome to interferon beta. So that's the line that's got a 1 hazard ratio. Now, we've already known that interferon beta is bad for aquaporin 4 disease, and mitoxantrone performed equally to interferon beta. And then to the left, you can see the drugs that we tend to use, Ritux and azathioprine. They are to the left, suggesting that they are more effective than interferon beta. So I showed you this algorithm earlier. I think it's probably prudent to remove cyclophosphamide and mitoxantrone from this. And I think then we need to come on to the randomized controlled trials. So I just want to mention this was an open label randomized study of azathioprine versus tocilizumab from China. Azathioprine is shown in red and tocilizumab in blue. And you can see that tocilizumab performs very well in time to relapse compared to azathioprine. But there have been some proper randomized controlled trials recently that have been reported, and I'll try and summarize the data from those. So here's the mechanism shown here when we think about the pathogenesis of NMOSD. So to the right, you have eculizumab, which works on inhibiting complement activation, which is thought to be very important in the pathogenesis of aquaporin 4 antibody positive patients. Inebilizumab, I did mention earlier, it binds to anti-CD19, and the anti-CD19 is expressed also in plasmablasts, so it might be more effective than anti-CD20s. And satralizumab is an inhibitor of IL-6 receptor, which is thought to be related to many different inflammatory processes that are probably involved in NMOSD, and it's related to tocilizumab. So here they're set out. The target I've already gone over. How they're given: satralizumab is given 4 weekly and it's subcut, so it might be able to be given at home. Eculizumab is given 2 weekly intravenously. That's quite difficult for a long-term treatment. And inebilizumab is given 6 monthly intravenously. So the designs were either they were added on to conventional immunosuppression because there were concerns about leaving patients untreated, or they were actually compared against placebo. So the inebilizumab study compared against placebo, and one of the satralizumab studies did, but the other satralizumab study was an add-on study, as was eculizumab. Because of the concern against placebo, the ratios of active to placebo tended to be higher in those where there was an increased risk because of having a chance of going on placebo. And the patients in the placebo studies tended to be recruited with milder disease because people would have been concerned about putting very aggressive active patients in a placebo arm. The satralizumab study did recruit some people of a younger age, so from 12 to 18-year-olds. The percentage of aquaporin 4 antibody patients varied. All eculizumab patients were aquaporin 4 antibody positive because of the complement pathogenesis. Satralizumab had 2/3 positive, and inebilizumab just over 90%. And then all used the outcome of time to relapse, because the minute they had a relapse, they were then put on active treatment simply because of the risk of damaging relapses. So the take-home message. So here's the overall risk of relapse, and in the subgroup with aquaporin 4 antibodies to look at like with like. So eculizumab had a 94% reduction in relapse risk. Satralizumab, 62 overall, but 79 in the aquaporin 4 antibody group on the add-on study, which is more comparable to eculizumab. And in the placebo-only studies, a 74% reduction with satralizumab versus 77 in inebilizumab in the aquaporin 4 positive group. There's another way to look at this, and this is to look at the percentage of patients that were relapse-free. We couldn't look at this in inebilizumab because this study was very short, because it was placebo-controlled, and they didn't want to risk patients being on the treatment for longer than they needed to in case they were receiving placebo. So if we look here, the percentage of relapse-free patients at 48 weeks. So in satralizumab and eculizumab, the percentage of patients that were relapse-free off treatment were pretty similar, 60 and 63%. So it looks like we're measuring a similar active group of patients. The percentage that were relapse-free in satralizumab on treatment was 92% versus 98% in eculizumab. If you look even longer at 96 weeks, again, the placebo groups look very similar, behave very similarly. And again, the percentage of patients in satralizumab or eculizumab who were relapse-free were more similar. So we've got 92% and 96%. So according to these results, satralizumab doesn't look that different in efficacy to eculizumab. What happened to the patients that were aquaporin 4 antibody negative? So as mentioned, not all the studies looked at this group, but satralizumab on the add-on study, you can see the aquaporin 4 antibody positive group did very well, but the aquaporin 4 antibody negative group were very similar to placebo, that's shown on the bottom. In the satralizumab placebo study, they reported relapse-free percentages at 48 and 96 weeks. And in fact, a lower percentage of those on the treatment were relapse-free than placebo, although it wasn't significant. In the inebilizumab study, they only had 17 ACPA4 antibody negative patients. There were 3 relapses in 13 patients on active drug, no relapses in 4 patients on placebo. So there's no signal here that it's working either for this drug in this group of patients. But what do we know about some of our conventional therapies? So these are ACPA4 antibody negative groups. On the left, this is a study led by Maureen Mealy and from the Johns Hopkins group. They looked at what happened to the ACPA4 antibody positive on the left and ACPA4 antibody negative on the right for rituximab and mycophenolate, pre-treatment relapse rate, post-treatment relapse rate, and it certainly seems to go down in both groups. And on the right, from that tacrolimus study where I showed you what happened to the ACPA4 antibody positive patients earlier, on the right, we have the negative patients. Now, there are only 8 of them, but they saw an 86% reduction in relapse rate, and 38% relapsed over 4 years in this particular group. The only thing I'd like to say is these aren't randomized controlled trials, and whenever you put a patient who's been relapsed on a treatment, there usually will be a regression towards the mean. So we don't know how much of the pre and post effect is due to that and how much is due to treatment. So I'm finally going to come on to MOG antibody disease. There isn't a lot of data out there really studying the effects of treatment and no treatment. So this is an observational study, but it's propensity match from the French group. And here is showing one of their results where they combined patients that were either on azathioprine, mycophenolate, or rituximab and compared them to their non-treated patients. These were MOG antibody patients who had a relapse. They were not monophasic patients, and they showed there was a significant improvement or a reduced chance of them relapsing when they were on treatment. If you look at the percentage of these patients that were free of relapse, on azathioprine, it was 54%, on mycophenolate and rituximab in the 70%, and in the MS disease modifying drugs down to 20%. So this sort of looks a little bit like the relative effects we see in ACPA4 antibody disease. However, there have been questions about whether MOG antibody patients actually do respond to rituximab. So the Liverpool lot were able to obtain data on 121 MOG antibody patients who'd been treated with rituximab from many different countries. And what they did was they looked at the risk of relapse given first line versus second line. And you can see that the pre to post relapse rate was reduced much greater in first line than second line. And you can see the time to relapse was much quicker if it was used second line than first line. On the right, I've shown this figure again that I showed earlier of time to relapse using first line treatment from the Korean group. And the top is the time to relapse for rituximab. I have then transposed the axes to make them equal. And if you run the time to relapse for the ACPA4 antibody patients first line, you can see that they appear to do better than the MOG patients, although this is not directly comparing the same patients. From the same French group, they reported the effects of Ritux in 29 ACPA4 patients and 16 MOG antibody patients. And in the ACPA4 patients, they noticed that only a quarter relapsed, and this was just over 3 years, whereas nearly 40% of the MOG patient relapsed, and this was over a much shorter time period. So it appears that actually Ritux did work better in the ACPA4 patients. And even more interesting was when they were looking at the B-cell suppression, the majority of the ACPA4 antibody patients only relapsed when their B-cells came up. However, the majority of their MOG antibody patients relapsed when their B-cells was still suppressed. It's not clear why this is. One possible explanation is that those long-lived plasma cells that are producing MOG antibodies hang around for much longer, even though the B cells are suppressed. So maybe rituximab would work if you used it for a longer time period. And then finally, coming on to the third scenario I mentioned about an observation of early relapse or early rebound in MOG antibody patients when they present. So this is some data that we looked at in our MOG antibody patients. And what we did, these were all onset attacks. And we looked at the time to relapse depending on how long they were given their prednisolone tailor. And you can see that those that were given it in less than 1 month or 1 to 3 months tended to relapse quicker than those that were given longer treatment courses before it was stopped. Now, of course, those that are given the longer courses are always on treatment. So maybe when you stop their steroids, they'll rebound equally. So we aligned the time when they stopped the prednisolone according to the length of treatment they were given. And you can still see that the longer courses tend to not rebound as much when it's stopped as those with the shorter courses. And so because of this, we follow on our patients for 6 months with low-dose prednisolone. And if the MOG antibodies are still present, we often will continue it for a further 6 months. So this is a summary taken into consideration on all the data that I've now shown you to explain how we treat patients. So aggressive, urgent, acute relapse treatment. I think that's for all. It doesn't matter really what their antibody is. IV methylprednisolone plus or minus plasma exchange or IVIG. If they've had a severe attack of transverse myelitis, there is a question about whether they should be given plasma exchange first line. And it's probable that if they've not got any better after the second line treatment, that third and fourth line have little to offer. But that may have been because in the study where they observed this, there was quite a big delay in some patients. If they have aquaporin 4 antibodies, then you should immunosuppress them from the word go. Rituximab is probably more effective than mycophenolate, probably more effective than azathioprine. We have the new drugs now where we are able to prescribe them, eculizumab, satralizumab, and inebilizumab. But we also have the old drugs, methotrexate, cyclosporin, and tacrolimus, but not to treat patients with MS-DMTs, except, of course, anti-CD20s, which we also use in aquaporin 4 antibody disease. So if they don't have aquaporin 4 antibodies and they have a single attack, if they are truly antibody negative, then we would just tail them off rather than just give IV treatment and stop. We tail them off steroids for about a month or 2. But if they have MOG antibodies, then we will give it for longer. Some people give shorter courses. We tend to give it for 6 months. If their MOG antibodies become negative, we stop then. Otherwise, if they're positive, we just give them another 6 months and stop. If they have relapsing disease and they are antibody negative and they have typical NMOSD, then you immunosuppress them with the treatments I've outlined, maybe prednisolone, azathioprine, mycophenolate, and Ritux. But there is no evidence, or in fact, the evidence suggests that the new monoclonals wouldn't be effective in this group. If they have MS-like features, and it can be difficult to be absolutely sure in the antibody negative group, then your best bet is to use an anti-CD20, which should work in MS and antibody disease, or azathioprine and mycophenolate, but be cautious about the MS-DMTs for the same reason as you are in aquaporin 4 antibody disease. If they have MOG antibody disease, again, you immunosuppress them. Now, there are some caveats. Some of these patients may have had a relapse 10 years ago, it was very mild. They go 10 years or even more, they have a very mild relapse. And long-term immunosuppression, the risks of that may not be worthwhile the benefits of a mild attack. So we always then discuss it with the patients. But if they have relapsing disease that is significant, then we would treat them with prednisolone or mycophenolate or azathioprine. I think rituximab, the jury's out as to whether it's partly effective, not effective. as yet. And in the pediatric population, there's some evidence that post-IVIG long-term is very effective. So that's my summary of the talk. And I'd like to thank all the collaborators, the highly specialized commissioning that commissions our clinical services, all the people that I work with, and our patients. Thank you.